Hey everyone, I'm Dr. Michael Sprintz, and I'm here to talk with you today about addiction in healthcare professionals, how to know and what to do. So first, I'd like to give you a quick background on who I am and why I'm giving this talk. So I'm originally trained as an anesthesiologist. I'm board certified in anesthesia. I'm board certified in pain medicine, and I'm also board certified in addiction medicine. Additionally, I've been in recovery myself from drugs and alcohol for 22 years. So I've been doing this for a long time, and I've been involved both as an addicted healthcare professional, as well as being in recovery, been in the impaired physicians program. And so I've really worked on it on both sides. I am currently in Houston, and I have a clinical practice that specializes in treating patients with both chronic pain and or addiction problem. So I'm a subject matter expert in that area of the intersection of chronic pain and addiction, and often have worked with impaired professionals as both a monitor and an evaluator. So that's a little background on me. As far as financial disclosures go, I have a lot. I do a lot of consulting. I do have a software company, Solarian, of which I'm founder and CEO. I do MPS consulting and media. And for Saluda, I'm a consultant and I do clinical trial research. For Spark Biomedical, I am also a consultant and do clinical trial research. And I am paid both a salary and in stock. In Nanomedical Systems, I'm a consultant with them, and I stock as well as consulting fees. Assurance Med Management, Med Answers, and Full Spectrum Healthcare Consulting, as well as Revelliance. I am a consultant, and with Med Answers, Full Spectrum, and Assurance Med Management, I do also have stock ownership in. Okay, so what are we going to talk about today? Today we're going to review the basis of and the neurobiology of addiction and its neurobiological basis. We're going to talk about and identify the warning signs of addiction and substance abuse in healthcare professionals. And these are also, you can use this information as well with your patients. It's not just healthcare professionals, it's with patients as well. And we're going to discuss ways to appropriately address and support a colleague exhibiting signs of addiction/substance use disorders. And moving forward, I'm going to use those terms, substance use disorder and addiction, interchangeably. I want to acknowledge the fact that they are not entirely identical, and that addiction covers a very broad range, not just of substance use disorders, but also addictive behaviors as well. But for the purpose of our talks, we're going to be doing this. I'm going to use them interchangeably. For the moment, though, I have to introduce my cat, Leo, who is, every time I do a presentation, he has to at least say hi once, because otherwise he'll meow the rest of the time. So anyone in the audience who's watching right now, do you know anyone in the healthcare field who's had a substance use problem? Most of the time at this point, I kind of ask, hey, does anyone not know anyone? Inevitably, there is someone in your life, professionally or personally, who has a substance use disorder. So here is the anesthesia residency class at Johns Hopkins, circa 1998. And that guy down right there was myself. That's me. I crashed in my addiction actually in 2000, and took me a while to get sober. It was I got sober October 15th of 2000 and spent a very long time in treatment. And one of the things that no one told me in the beginning was that if I got into recovery and I did all the things I was supposed to do to stay into recovery, that my career would be okay, that I would still be able to work, that I would still have a career, that I wasn't going to jail. And those are things that are really important to recognize. So for anyone out there who may be struggling with a possible substance use disorder, or you know someone who is, one of the most important things, and I'm saying this up front because it's really important that you recognize this, the goal with recovery and with impaired physician programs is about helping you get better and get back to work. The goal is not to take your license. The goal is not to lose your career. And no one told me that when I first started. So I think it's really important that I bring that up right from the start, that even if you do have a problem, There's a tremendous amount of help out there for you, especially nowadays with after, the opioid crisis and the substance abuse crisis that has been going on, and especially which has escalated after COVID. Let's acknowledge something. We're all burned out. We're all tired. Everyone's working hard. Everyone's working harder than they've worked, and it's really stressful. Reimbursement is down, our hours are longer. It's a hard time to be a physician and a healthcare professional in general. So I want to acknowledge that. And as part of that issue is that, and we'll talk about this, is that there are going to be people who develop substance use disorders. And that's important to acknowledge, but I just want you to know that there's help out there, and it doesn't mean the end of your career. So when we talk about substance use disorders in general, in 2019, the use of their 13% of people over 12 years old used an illicit drug in the past month. Think about that. That's a lot of people. And then about 10%, 10 to 12% of physicians will develop a substance use disorder during their career. And that actually, the data is from 2009. The post-COVID numbers are probably higher. I'm being incredibly conservative. And these are numbers that are coming out of people who were diagnosed with a substance use disorder, not all the people that actually have a substance use disorder and are not diagnosed, the silently addicted, or the people with the disease that have not been identified yet. And also, I will talk interchangeably. I'm primarily going to be talking to physicians because you're my audience, you're the physicians. But at times I'll use healthcare professional. And I think that's really important because as physicians, we are the leader of the healthcare team. And as the leaders of the healthcare team, we're going to be interacting with healthcare professionals at every single level, not just from our colleagues and our mid-level providers to ancillary staff. The issues that we're dealing with here span every level of profession in the healthcare field. So you can apply this not just to physicians, but really to any healthcare professional. So preventing addiction. Right now, I don't know how many of you are out there golfing, but when we think about, the slice, when someone slices into the woods, when does that happen? Does it happen when the ball goes into the woods? No. The time that when you slice into the woods, and for the record, I haven't golfed, the windmill always beat me every time. So I haven't done a lot of golfing regularly, but I've watched enough to watch when someone slices and it goes into the woods, it doesn't go into the woods when it hits the woods. It goes into the woods at the point of contact and just after. We're talking right down here at this first little dot. And when we think about it, think about addiction this way. How are we identifying people who have addiction problems right now? We're identifying them here when they're in the woods. And this is Leo, again, who needs to be a part of this. So they're in the woods. And as a result of that, what happens is, people are getting busted when they're already at the end stage of their addiction. And that's the worst time. I mean, it's better than never. But the reality is that you want to identify people as soon as possible in the progress of their addiction, right? So if we can identify someone here, right at the point of contact, right when they start to develop it, and then utilize tools and interventions to help prevent them from ending up losing their life, losing their family, losing their job, losing all the things that can happen at the end of addiction. And that's important. It's not just about our jobs. It's about our families. It's about our lives. It's really about our self-esteem and the loathing that goes on in active addiction. At the end of addiction, it's a horrible feeling on the inside. People are not having fun. Fun ends a long, long time in the progress of addiction. At the end of addiction, it's about unconsciousness. It's about not feeling at all. And if we can help identify someone much sooner, then there's a lot of hope. Okay, so what is addiction? Well, I like to quote Cookie Monster, who pretty much said it best. Addiction is when one cookie is never enough. Okay, Well, let's first actually talk about false beliefs about addiction and substance use disorders. These are the myths that are there. Okay. So, the common myth was like, oh, well, these people, they have a moral deficiency or they lack willpower. If they had enough willpower, they could stop using. It only affects poor people. Well, no, it doesn't. It affects everyone. And if you're intelligent, beautiful, or successful, those people don't get addicted. Why? Well, because they're intelligent, they're beautiful, and they're successful. They can't be addicted. And if they don't miss work, they can't have an addiction problem. That was a funny thing because with myself, when I was in high school, my parents, and I was already displaying signs of this, I got great grades though. And my parents talked themselves out of it thinking, well, gosh, he's got great grades. He can't have a drug problem. Meanwhile, I'm buying keggers, doing drugs, all that. And part of the problem that happens is that we've got stigma, and it's this stigma. And I'm sure there are some people in the audience right now who have had parents who had an addiction problem, and it was a horrible situation growing up in. And a lot of times people will associate that all addicts are like my mom or my dad who beat me or who was abusive to me in some way. And part of what we're trying to raise awareness is that um, people in addiction do bad things. It doesn't excuse it, and people have to take responsibility for that. But our ability to help people rather than just punish people can create a whole different opportunity in the world. I'm here today because there were systems in place to identify me and help me actually to help me get the help I needed. So I'm not in jail, but instead I'm going around the country and I'm consulting with companies and I'm talking with groups like yourself about addiction and how to better treat your patients, how to manage chronic pain with addiction patients, how to help your colleagues who may be struggling with a problem that you may not know about or you may know about. So addiction is a brain disease. And ASAM the American Society of Addiction Medicine revised its definition of addiction in 2019. And it is now defined as a treatable chronic medical disease involving complex interactions among brain circuits, genetics, the environment, and an individual's life experience. They further go on that people with addiction engage in behaviors that are compulsive and often continue despite harmful consequences. The bottom line is bad things happen and I keep doing it. That's a huge problem. People without addiction problems, if they're doing something and a bad thing happens, they stop doing it. Ask anyone who's gotten one DUI and they're not an alcoholic. They don't get a second or a third DUI. And the most important part of this is that prevention efforts and treatment approaches for addiction are generally as successful as those for other chronic diseases like asthma, hypertension, diabetes. The treatment approaches are as successful, even though the stigma and the perception is that it's not. 4 C's and 2 D's. So addiction is characterized by impaired control, craving, compulsive use, and craving meaning that you want it, you need to eat it. I don't know if anyone's ever eaten Oreos before, but I have cravings for Oreos. I have to admit that. Compulsive use, when you start, you can't stop. And continued use despite adverse consequences. So I keep using despite bad things happening. And it's always accompanied by denial. Addiction is the only disease that tells you you don't have it. Okay. And then the last part is there's also a dysfunctional emotional response. Generally speaking, our emotional growth stops when you start using drugs and alcohol. And so the way that people cope with addiction is dysfunctional. They're like children or teenagers, which of course, anyone who's had children or teenagers, you know what I'm talking about. And this has been confirmed in animal studies. The good news is Ferris is doing well. He's now been in recovery for about 15 years, so we're really happy to have him around. So here's the thing about addiction. Addiction is in the brain, and the brain doesn't care whether it's alcohol, cocaine, chocolate cake, food, sex, gambling, internet, shopping, work, exercise. It's all about the dopamine burst in the reward center of the brain. Okay, so well, how do I get addiction? Well, there is a genetic predisposition. It is absolutely hereditary. We've identified specific haplotypes and allele combinations that have been confirmed to increase the risks for the development of addiction. You look at families. We know that addiction is genetic. But then you also have, it's important, the old question used to be, well, is it nature or nurture? Well, if I don't have the genes for it, no one in my family has addiction, that means I can't get addicted. Well, that's not actually true. What we know is that what we have often is, and just because you have addiction in your family doesn't mean that you will develop addiction. For example, in my immediate nuclear family, neither of my parents have addictive disease, neither does my sister. I do. Now, in my lineage, I have a great-grandfather who was an addict. I have a great-uncle who's an addict. I've got an uncle who's an addict or an alcoholic. I've got cousins who are. So it runs in my family. I have the genetic predisposition. But then you also have to add things to it. Then it also means genetic predisposition plus stress plus drug exposure or behavior exposure or trauma equals addiction. So trauma is a really important thing to realize. And I would encourage all of you to do some of your own education on trauma. I'm talking physical trauma, I'm talking emotional, physical, sexual trauma. Often it occurs in childhood, but it can occur in adulthood, just like with that happens often in veterans. But especially when it happens in childhood, trauma changes the brain. It changes the way that the brain circuitry develops, and it increases the probability of developing addiction, even if you don't have a genetic predisposition. And that's really important. You can still develop addiction even without having the genetics. The genetics just mean you have a higher probability than not of developing it. Factors associated with the risk of addiction. Well, there's a lot more than this, but some big ones are the fact that you have a personal history of it, or you do. Well, gosh, risk of substance use disorder. Yeah, if you already got it, you already got it. That was kind of a duh one. Close family history of substance use disorder. We're talking about the genetics, right? So mother, father, grandparents, siblings, kids, anyone first-degree relatives. That usually means that you've got a higher risk than someone who doesn't have those. Psychiatric diagnoses are associated with a higher risk of a substance use disorder. ADHD, bipolar, depression, anxiety, all of those things, and schizophrenia as well. Psychiatric illnesses all give you a higher risk of developing a substance use disorder. Again, I'm talking about risk, not certainty. Okay, so not everyone who has depression has a substance use problem. They're just at risk for it more than someone who doesn't have depression. Okay, so it's important to understand the context. People who smoke, well, it's a nicotine addiction, so go figure. Personal history of trauma, just like I was talking about. Aberrant drug-related behaviors. Well, if you're hanging out with everyone around you that does drugs, there's a good probability you may have a substance use problem. If you find yourself overusing your medicine, you're running out of your pain pills 2 weeks early, and your pain is pretty well treated, there's a good probability that you may have a substance use disorder. And age less than 30, sometimes people say 35. Younger people tend to have a higher risk of substance use disorders. If you are 65 years old, you've never had an alcohol problem, you've never smoked in your life, and you drink once a week and you have one drink at a time, you are probably not an addict from a substance use perspective. Now, there are people who are addicted to food, to exercise, to work, etc. So there are other behavioral addictions, though. So I want to talk for a moment about the ACEs study, and I'd recommend that everyone take a look at that as well. ACEs stands for the Adverse Childhood Experiences Study. And this was a really just landmark, groundbreaking study that showed it had 10 questions. And the more and these questions were different life experiences that someone has in childhood, like they live with someone who's an active drug addict, they witnessed violence in their home, One of their parents are incarcerated, et cetera, et cetera. There were 10 total. And the more yeses that a person checked on it, the higher degree that they would have an early death or have a greater morbidity and mortality than someone who didn't have these adverse childhood experiences, including addiction, or should I say, and especially with addiction. Okay, so here we are. I'm at work. Well, how do I identify someone who's got a substance use problem in a colleague? How do I know who's got a problem and who doesn't? I mean, everyone goes out and drinks. Why would someone have a problem? So we'll start first with, well, what does an impaired professional look like? He kind of looks like an administrator, but I'll leave it at that. Is he an impaired professional? Are you sure? Yeah, he is, by the way. Okay, so we'll talk again. Here are more myths and false beliefs about addiction with healthcare professionals. Well, addicts and alcoholics only use street drugs. So no one in a hospital would ever abuse hospital drugs. Impaired professionals have a long history of drug or alcohol abuse. Not necessarily. Sometimes impaired professionals may not develop addiction all the way until their attendings. Sometimes people, a lot with anesthesiologists, they had the genetics but never developed the disorder. And then they wanted to see what their patients were feeling like. And I've heard that on more than one occasion. And next thing you know, they turn on the genes and boom, they're hooked. And that impaired professionals are easy to recognize. That is probably one of the most important false myths of impaired professionals. Work productivity or work function is usually the last thing to go in the progression of addiction. And again, addiction is a progressive disease that is fatal if left untreated. But if treated, have a great life. So it's not always as obvious as you may think. So the reality about an impaired professional, and I'm talking about a substance use disorder impaired professional, I'm not talking about impairment in other ways. It can happen to anyone. It can happen in any specialty, any gender, any age. Medical training does not provide immunity. Intelligence does not prevent abuse nor addiction. And neither does being an attending, chief resident, chief of staff. Your status doesn't freaking matter. Addiction doesn't care. And I remember when I was actually invited to give this talk by an individual who was my chief resident when I was at Hopkins during my anesthesia residency when I crashed in my addiction and was sent to treatment. But I will still remember that first day of the orientation when we started, and they gave us a talk on addiction. And there were 27 people in my residency class that year in 98. And they said, one of you will come down with an addiction problem. And I remember thinking to myself, and I had already started using IV drugs. And I thought to myself, nah, it's not going to be me. Oh, first of all, I was wrong completely. Two, that also shows the denial that was going on. But it was the reality that, 1 in 30, and it's probably a little bit higher now, of these classes of healthcare professionals are going to have a substance use problem. Okay, so well, how do I know? So what happens with addiction is you get it's a sequential progressive deterioration in every facet of your life. As addiction gets worse, the world shrinks. We start to isolate. We stop doing the things we used to do. We stop hanging out with friends. We pull away emotionally, we pull away physically, because as the addiction gets worse, the desire to not be found out starts to take control, and addiction really becomes a full-time job. And job performance is the last thing to go. So how do you know? Well, the first thing is to be present, be aware, look at your colleagues. If you've had a friend that you've been working with for years and suddenly something's different and they're just not right, or they're they no longer care about their hygiene when they used to be very meticulous about their hygiene. Those are little signs and symptoms. And generally, if it feels like something's wrong, it may be. And it's important to be present and be aware. Seek to understand the whole picture. So not everyone has a substance use disorder whose hygiene changes a little bit. Not everyone has a substance use disorder who happens to get drunk one night, but some do. And it's important that you look at the whole picture, not just a data point. So if you start to have concerns about a colleague, ask your other colleagues or your supervisor. And at times it can be other causes or issues. Sometimes, for instance, people with schizophrenia, they actually self-medicate to manage their so it looks like substance use disorder, but what it really is untreated schizophrenia. That can happen with other things like depression and anxiety. It's not an excuse. It means that they actually need to be addressed and treated. For instance, if you have a colleague or you have someone else, you don't have to take this on yourself. Check with other people. Hey, have you noticed any changes in Bob? He seems different. He seems like he may be struggling with something. Have you noticed this, or is that just me? And a couple people will either understand or agree or not. And then I'll talk with you about how to handle this a little bit later. An impaired CV. So if you're someone who's in a position to do hiring, when you look at a CV, you really want to look a little closer because a CV tells you their story. Are there multiple job changes? Are there unexplained time lapses between jobs? Are there frequent moves? A lot of people with substance use disorders take locum tenens jobs because they're only here for a month or 2 months, and then boom, they're gone. Do they have a lot of hospitalizations that otherwise can't be explained? A very complicated and hard to decipher medical history. Inappropriate professional references. Generally, if you're hiring someone, especially if for a physician, and you get a reference that says this person worked at our hospital, period, because there are certain laws and rules about what we can say and not say, or this person did an adequate job. Those are keys and clues that something might be going on. Wrong jobs for the skills. So, for instance, I was a licensed physician, and I was working at Bed Bath & Beyond. Go figure. And a decline in professional productivity. You see a change in job performance. Bob was doing great, or Jane was doing fantastic and awesome, and then suddenly they were doing so great, and then I don't know what's going on, but they suck now. They're missing things. They're not behaving professionally. Their professional skills are not what they used to be, and it changed pretty rapidly. So here's, excuse me, here's an important point. Behaviors are your breadcrumbs. Behaviors will tell you where someone is at. Common signs of behaviors of a healthcare professional with a possible substance use disorder: mood swings, missing in action, meaning they don't respond to their texts, their pages, especially if they're on call, or they take an excessively long time to respond. They arrive really, really early, or they stay really, really late. And they do that because when less people are around, you've got access to hospital drugs. Showing up at odd work hours or when off duty. So if you're showing up at work and you're not supposed to be at work, that most normal people don't do that. A lot of accidents and traumas. Someone who doesn't have any reason to have a bunch of falls, but yet they keep having falls or head trauma or something like that. Car accidents, multiple ones, etc. Again, a change in personal hygiene. They were very meticulous, and now they're not even wearing a tie. Sometimes they don't. It doesn't seem like they've even showered. Nodding off. Obviously, someone falls asleep in the middle of lunchtime. Well, that's a good clue too, especially if they weren't on call the night before. Unexplained bruises, a lot of personal life issues. Now, again, we all have personal life issues. Remember to look at the whole picture, but sometimes the personal life issues can be the result of an undiagnosed substance use problem. Sometimes a personal life issue can tip someone over the scale to start a substance use problem. So it's important to really get a whole picture. People who are wearing long sleeves at work, or they never did before, but suddenly they're all wearing long sleeves. That's to hide bruises from IV. Picking up extra shifts every chance they get. And again, sometimes people just need money. Sometimes it can be something else. If they ask anyone, if they ask you or someone else or a colleague for a script, in particularly a controlled substance of any kind, and multiple DUIs. Well, really, even one DUI raises awareness, and most of the medical boards ask those questions anyways. But nonetheless, more than one DUI, it's almost there is a extremely high probability that they are that they have a substance use problem. And unusually hyper agitated, talkative. And I have a video here. I'm not sure if it'll play or not, but from the movie Trainspotting, that was a great example of agitation with meth.
No, they've been doing well in their cause, you know, they go. There's too much discrimination on this green man. Because they're both schooled, right? We're all in this together. I wanted to put across the general idea rather than the details. Like, people get all hung up on details. Like, what school did I go to? How many O grades did I get? Could be like 6. Could be none. It's not important. What is important is that I am yes.
So clearly, I don't know about you, I didn't understand a word he said, or very, very little of it, and it wasn't the accent. Oh, hold on. Now we go to the next one. Okay. How are some objective ways to identify a colleague with a possible substance use disorder? Well, most places have a drug-free workplace policy that allows supervisors to drug test an individual if they seem impaired at work. So we're talking about someone who comes into work, they smell like alcohol, and you're concerned because they're a surgeon and they're about to do a case. So drug testing is one way to do that. You can do medication audits of the drug dispensing systems. So those, basically the drug ATMs, there's a couple different brands of that. But the bottom line is you compare those, how much controlled substances does someone take out compared to their colleagues? And you compare drug utilization versus other providers of the same specialty. And same specialty is really important. You want to compare apples to apples, not a pediatrician comparing them to a chronic pain doctor in their prescribing of opioids. That's not really a fair deal. So you want to do it like that because what you will find is you'll find someone who is either checking out a lot more drugs or using a lot more drugs or prescribing a lot more drugs to a standard deviation more. And I'm ballparking that up to be clear, but they do it a lot more than what their colleagues are either locally, nationally, or in your hospital system. A really important thing is to start tracking number of patient complaints. And usually that occurs with opioid abuse, where the patients are complaining of pain, especially for anesthesia providers. They come out and they're in the PACU and they're complaining of pain. But this happens in the ER. This happens in the floor with impaired nursing staff, where they're taking the medications and they're not giving the medications to the patient. So comparing the amount and frequency of pain complaints are important, but also patient complaints about a provider in general is important to understand. Remember, we talked about mood swings. That's something to think about, that if suddenly someone who's doing really well gets a patient complaint because they were yelling at a patient, well, that's not consistent with their personality. That's something to look into. And then, of course, direct observation of use. They have their hand in the cookie jar. You walk into the call room and there's a needle in their arm or they're passed out or something. There's obvious stuff that we are all aware of. And, that's common sense. If you see someone using, well, they're using, that's when you have to start going, okay, how do we manage this? Well, I'm glad you asked that question. Now what? How do we appropriately support a colleague with a suspected substance use disorder? Okay, and so I wrote it like that, and I stated it this way: is how do we appropriately support a colleague rather than how do we catch him and bust him? Because remember, the goal ultimately isn't about punishment. The goal is about identifying someone who's got a disease that's going to kill them or someone else if it's left untreated. And so what we're doing is we're helping them. And that's kind of challenging at first to think about. we in the helping professions are enablers. So the first thing to remember here is this is not the ostrich mentality is not an effective strategy for dealing with this. And the reality is, and we're looking at it right now in the opioid crisis that is and it's really a substance abuse crisis. It is still going on. Pre-COVID, intra-COVID, post-COVID. It is still here. It's actually worse than it was pre-COVID. But the fact is that part of the problem that got us here is no one wanted to see, no one wanted to identify it. And it's important that we stop doing that and we look at it for what it is. So this is a Far Side cartoon. And the doors say, I don't know if you can read it, damned if you do, damned if you don't. Okay. So this is an uncomfortable topic, especially when we're talking about how do I deal with a colleague who has a problem like this. And so the general initial response is to avoid it. So here's some of the rationalizations we tell ourselves to avoid addressing the problem of a colleague or a coworker with a substance use disorder. Well, it's not that bad. Everyone parties, but not to the degree they do. I don't want them to lose their job or their license. That's a really big one. Everyone thinks that they're helping the person by not reporting them or by not getting them into treatment. Oh, because they're going to lose their job or their license. I'm telling you, with active addiction, they will lose their job and their license eventually if it is left untreated. Eventually they will, because inevitably it's the progressive disease and you just can't keep your crap together. And eventually people get hurt or the individual themselves get hurt. Another one, this is often, administration is like, well, we can't afford to lose Dr. So-and-so. They're a great producer for the hospital or for the clinic or the practice or whatever. So you're making a financial decision over the wellness of your colleague. Think about that for a minute. Now, I get it. I own my own practice, like production and making sure you meet payroll and making sure that you handle your financial part of the healthcare business is absolutely vital and essential. I respect it completely. But the reality is having someone in your employ who has an untreated substance use disorder is a massive risk to your company. It is a huge risk. And so even though they may be a great producer, and you see it in Hollywood, you see it in athletes where they just give them everything they need, just, get them on stage, until they just crash and burn and then they toss them out. We can't do this in healthcare. We shouldn't be doing it in Hollywood or professional sports either. These are people who need help. And the fact is that you may imagine how great a producer they will be sober. And that's an important thing to think about. I'm a heck of a lot more amazing physician, and I'm bringing in a lot more value to my company with me being sober than I ever did when I was using. Next one, they're my friend. I can't tell on them. This is what enablers do. You're not telling on them. You're saving your friend's life. It's really that simple. And a good friend cares enough to risk that to save their friend's life because they matter. Well, they're in the middle of divorce. The only thing they have is their beer, or their wine, or whatever. That's, everything else. Their whole life's falling to shit. Now they're going to get in trouble and blah, 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 blah. Well, they're in the middle of a divorce that may be a reason or a cause of it. It may not. I don't know, right? Everything's different. But the fact is that the fact that someone is going through a personal life challenge is not an excuse not to get them the help they need. In fact, getting them the help they need actually then they will have support to help them through the middle of a divorce or a move or the death of someone they care about in the family. Whiskey doesn't listen to me. It just numbs me. Okay. Having a professional who can help me is important. So the appropriate way to support/report a colleague You want to have a written policy and protocol on how to handle a healthcare professional who's suspected of having a substance use disorder. A clear written policy and protocol eliminates your need to make subjective decisions. Boom, 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 boom. There it is. And it's equal, and it supports equity. It supports equity, diversity. Here's our policy. Doesn't matter who you are, here's our policy. Boom. So if you're not the person in charge, if you see a colleague or a coworker who you think may have a problem and you're not the person in charge, notify the person in charge, whether that's the charge nurse, supervisor, administrator, chief of the practice, whomever, person in charge. You also want to check your own state reporting laws. So every state, not every state, but many states have laws that stipulate about reporting requirements for healthcare professionals if you have a colleague you suspect of it. And sometimes if you don't report a colleague who you know has a substance use disorder, you can put your own license at risk. If you are the person in charge, and if you're not the person in charge right now, at some point you probably will be, so this is important to still pay attention. Most important thing is you do this confidentially and respectfully. You bring another person with you. You want to have, you want a witness there for all of this. Ideally, if you're a different gender orientation than the individual that you're having this conversation with, bringing in another person who is the same orientation or gender of, I'm sorry, I apologize, who is the same gender identified person as the individual you are addressing is important. And that eliminates accusations of impropriety in any kind of way. Be non-judgmental. They have a disease. They're not bad people. Stick to facts, not opinions. And when I say stick to facts, I mean, you were seen doing this. This was reported. The patient reported this. The medication utilization reports are significantly different than the other. Not, John thinks you're an addict, or Jane said that she was sure that you were. Something like that. Stick with facts, not opinions. And give the healthcare professional, give them a chance to respond and listen. Let them talk. They have feelings, and it's going to be an incredibly stressful and terrifying experience for them. Let them be heard. Sometimes they may just go, yeah, I'm kind of relieved. I do have a problem and I need help. Sometimes they may completely deny it. What are you talking about? No way, blah, 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 blah. But give them a chance to respond. Be prepared to de-escalate the situation. The goal is not about egos, like, rah, 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 you got it, you got the problem. Because right now, you're not 100% sure, but you suspect there's a problem. You still need to get more information. So if someone gets into denial and they bow up and they're bullying or yelling, and you want to de-escalate it, so prepare for that, okay? It's always about de-escalation. It's not about fighting for who's right. Have a plan in place. This is not something you should wing, right? So have a plan in place. Do a mock intervention with the appropriate people in your organization so you can practice what happens when they do this, what happens when they do that. How do we want to handle this? Have that plan in place. Have a place where they can go for treatment already set up. If you think they have a problem and you suspect it, have a relationship with a treatment center that you can call up, say, hey, look, I've got a colleague here, a physician or a healthcare provider who has a problem. Do you have a bed available? And get all that set beforehand. So if the person goes, yeah, I got a problem, I need help, you can get them there right away. Give direct recommendations for next steps and expectations. Be clear, be decisive, hold your boundaries. They oftentimes they'll try to talk you out of it about a million different reasons about why this and that and that and that and this and this. Hold a boundary. If you're not if you are not a professional in the substance abuse treatment world, you want them to have an evaluation, and then let a professional who's an expert in that area evaluate them. If there's no problem, great. If there is, then they're already in a place where they can get help. You want to escort the physician or healthcare professional for drug testing. You don't want to just send them and have no one go with them, because there's a million different ways to beat a drug test. And that's a different talk for a different day. But you want to be with them and eyeball them, not just to make sure that they're not going to try and taint or fake their drug test, but more importantly, to make sure they're safe. A lot of times people harm themselves after an intervention like this. Oh, I lost my job. I'm going to lose everything. Everything's gone. I might as well kill myself. And it happens. So we don't want to leave the individual alone after an intervention, because there is the possibility of suicide or homicide. Interventions. So you want a team leader. You want to have a team selected. This is under the have a plan part. You want the location to be quiet, non-threatening, and neutral. An office where there's not a lot of people around. You don't want to do this in front of their colleagues. You never want to do this in front of a bunch of other people. The shame already is enough. This should be private and confidential in a quiet area. Again, think de-escalation. You want to make sure that you have your goals set. You want to document the events before, after the intervention. You want to make sure that you do it. Again, rehearse. Plan A, plan B, make sure you do those things. Remember, the goal is non-disciplinary assistance first. We want to get people into recovery, not punish them. The goal is to help them get well, because when they get well, they're going to be great employees, and they will remember how you helped them. To this day, I will never forget and be forever grateful to my program director, Jeff Kirsch, who gave the most loving intervention and supported me throughout my recovery. I would do anything for that man. He handled it the way I hope everyone else handles that kind of situation. You can call, every state has an impaired professionals program. You can call them if you think there's a problem. Call them before you call the board or the police. Please call the impaired professionals program first before you call the board or the police. There's a few instances where that's not, but you would probably know those. If someone's holding a gun to you, then, you kind of need to call the police. Challenge and risks when engaging a healthcare professional. So you're in the middle of an intervention, you're talking with them, and you give them a chance to talk, and they're like, I don't have a problem. Or they may refuse to take a drug test, or they threaten you or someone else, or they're projecting the blame on everyone else. Those are things you want to have talked about and planned. Okay, how do I deal with this? How do I deal if they refuse a drug test? Do I just let them go back to work? Or do I count that as a positive? How do I deal with threats? Do I call the police at that point if they're threatening me? That's a good idea. Your safety comes first and foremost. Projecting blame. That's really common. It's everyone else's fault. It's not my fault. I'm a drug addict. And again, that goes back to the denial part. All of those things are it's not good or bad. These are just things that you have to be prepared to face. Suicide, which we were talking about earlier, about not leaving the individual alone. Harm to self and or others. So-and-so ratted me out. And, I actually had a colleague when I was in my residency and I was in sobriety who ended up threatening me because he thought I was the problem. I wasn't the problem. Running away, literally running away. And continue use if allowed to stay practicing. Sometimes administration or sometimes the person in charge will make a decision that they're just going to let them go back to work. I don't recommend that. There can be really bad consequences with that. And the impact to the organization. Well, if someone is a good producer, there is going to be an impact to the organization. But I want you to take a larger perspective, and in the long term, the organization, it's a risk-benefit ratio, and the benefits of helping this person into treatment always outweighs the risks. Ask for help. If you're not an expert in this area, if everything that I talked about made you feel a little uncomfortable and a little awkward, that's okay. That's normal. There's less than 4% of all physicians are trained in addiction medicine. And I don't know about you, but I never had any training in addiction. I think I had one hour course when I was in medical school. I think that's changing now. I believe it's changing now. But the reality is most of us in practice never had experience in dealing with addiction in general, let alone how do I address a colleague who has a problem with this. This is hard stuff, and I want to honor that as well. And the important thing is you don't have to do it alone. Ask for help. If you're doing a procedure that you've never done before since fellowship or residency, what do? Well, you read up on that procedure again. You call a colleague who knows how to do that procedure, and you're like, "Hey, look, you know, I've got this, T3 kyphoplasty that I'm going to be doing tomorrow, and I'm nervous. I've never done one that high. Blah blah. What do I do? Oh." And then their colleague goes, "Yeah, you do this, you do that, you do that, you do this." It's the same thing when dealing with someone that you're concerned with a substance use disorder. Call up the Impaired Professionals Program. Ask them, "Hey, how do I handle this?" They will help you. They will walk you through that. They can even send out interventionalists who can help do an intervention. Okay, you don't have to handle this on your own. Impairment does not have to end a career. Untreated addiction will. It is that simple. I know a number of people who were intervened on that went into treatment that not only are amazing physicians, but the perspective and the understanding, especially the fact that we have this massive opioid crisis or substance abuse crisis going on. So you know that everyone's dealing with patients who have these issues. Having someone on your staff in recovery is a huge asset, not liability, a huge asset. Someone with nice, stable recovery, they know how to handle things that you may not. When I started my practice, I mean, I understand addiction, I understand chronic pain, and my partners. But when they first started, I was able to help them understand not just from the physician side, but I also helped them understand, well, how does an addict behave? How do they think? Because people with addiction, we don't think normally. There's a different kind of logic. But if you understand that, then you can know how to manage them. All right, I'm in. Let's do this. So what is a Impaired Professionals Program, or a PHP, Professional Health Program? It's a program of prevention, detection, intervention, rehabilitation, and monitoring of licensees with potentially impairing illnesses approved and or recognized by the state medical board. The bottom line is Impaired Professional Program are there to help healthcare professionals get into recovery and stay in recovery. They're an intermediary between the medical boards, or the whatever professional boards there are, and the provider. And they work together. So the medical boards or the nursing boards, the pharmacy boards, they work with the Impaired Professionals Program together in order to help keep people safe, because the board's job is to help keep the public safe, not the doctor. So it's about keeping the public safe and keeping the healthcare professionals safe. What's amazing about the Impaired Professionals Program is they work as advocates to help the healthcare professionals successfully return to clinical practice. The goal is to help you get back to practice, not kick you out. So planning it all on your own is, and doing it on your own, or should I say not doing it on your own, it'll end up much worse than working with the PHPs, because the PHPs will show up for you with the board and advocate for you. And as long as you're doing what you need to do within the PHP program, you're fine. Structure is essential, and apparently so is grammar, because I need to spell essential right. Structure is essential for long-term success in recovery. All right. Addicts hate structure, but thrive really well in a healthy way with structure. So you want an aftercare plan, group therapy, individual therapy, some type of spiritual growth, whatever that program is person dependent. Accountability, drug testing, monitoring them with either the PDMPs, or having accountability. For instance, I actually am a monitor for physicians in early recovery. And so I write to the PHP to let them know how they're doing, and I meet frequently with that individual, and to check in and see how they're doing, see what's going on. So there's a level of accountability and responsibility. Activities. When people are using, they stop doing all their other activities. You want to get them involved in more activities, because initially it's about re-engaging in life because we had given up on life. And anti-craving medications that are non-addictive. Okay. You have to remember that as a physician, we are in a safety sensitive position. And so that means that sometimes there's a lot of places that are not going to be okay with buprenorphine for opioid addiction. But something like Vivitrol or naltrexone, which decreases cravings for alcohol or opioids and is non-addictive, is great. I had taken that for 2 years as part of my agreement to go back to and finish my anesthesia residency. And it was great. I didn't have the cravings that I had before. Effective communication is key. Talk with your state impaired professionals program. Learn from each other. They can teach you, but you can also teach them. Okay. So they want to know, addiction docs may not, I see this all the time in pain management. Pain doctors don't understand addiction, and addiction doctors are not comfortable and don't understand pain management. And so having that communication is really vital because the overlap is so significant. Talk with your colleagues. Keep in communication. Hey, look, John, you're doing great. How are things going? And be authentic about it. And if you really, really don't give a crap about it, then don't ask. And you're probably not that close anyways, and someone else will be doing that. But really, especially if you are the supervisor or you're someone who's involved in their long-term care, keep open doors of communication in a non-judgmental way. That really does make all the difference. The individual is going to have shame and guilt and feel horrible about everything that happened. You don't have to make it worse. You can support them, because as they get healthier, emotionally healthier, it's not just about not using, it's about emotional sobriety and emotional maturity. And as they get healthier, they are going to be an amazing rock within your organization. People with long-term good emotional and consistent sobriety and recovery are amazing people to have in your organization, because they've gone through and done so much work that can really help the organization in a lot of intangible ways. Stay present and connected. Do's: educate yourself. I covered a whole bunch of stuff today. What I want you to do is I want to challenge you to go out and read just a little bit on how do I identify someone, or how do I have a difficult conversation with a colleague. It doesn't even have to be about substance abuse, but how do I have a difficult conversation in a healthy way? Learn what your organization's policies and procedures are. That's really important so that you're not guessing what to do when you need to make a decision. Know what your legal and ethical responsibilities are, and that goes back to the state laws and state reporting. And of course, ask for help. Don'ts. Do not ignore poor performance, especially when it's unusual and unexpected. Don't lighten or change the physician's patient assignment just to make it easier for them if they're having problems. Don't accept excuses. Now, again, this is under the context of the whole picture, right? There may be reasons why people use, but it's not necessarily an excuse. And do not allow yourself to be manipulated or fear confronting a colleague if patient safety is in jeopardy. Patient safety comes before physician licenses. We take care of the patients. We make sure the patients are safe. We make sure our staff is safe. We make sure that we are safe. Okay. So again, don't have interventions alone. You always want someone else with you. Safety is important for everyone. Well, the question I always get is, okay, well, what if they have chronic pain, and can they go back to work taking Vicodin if they were abusing Vicodin, but they've got a herniated disc in their back? And just for a background, this is where I am an expert in, and I do a lot of evaluations on healthcare professionals with pain complaints. The first issue is the pain appropriate for opioids or benzos or whatever? And is the patient appropriate? Again, especially in early sobriety, controlled substances for the most part, are generally not appropriate for someone in early sobriety, for a physician or a healthcare professional in early sobriety going back into work. It's generally not a good idea. So this is where you have them evaluated by professionals for that. But if you're going to have them evaluated because of a pain complaint, make sure that the pain doctor has experience with addiction. If they don't, you're setting yourself up for some trouble. And again, please feel free to call me or text me or email if you have a question about a patient. I'm happy to help anytime. Multimodal management for pain and addiction. Summary. So the bottom line is addiction is a brain disease and it's treatable. Don't judge a book by its cover. Genetics, stress, trauma, emotional, physical, psychological, sexual, all of those things in adulthood or childhood can increase the risk for developing addiction. How do I tell a colleague may have a substance use disorder? Be present. Look at the whole picture. Remember that behaviors are your breadcrumbs. Do objective testing. What do I do? Remember, the goal first is confirm they actually do have a problem and then safely get them the help they need. Have a plan, do it confidentially, be non-judgmental, focus on the facts, prepare to de-escalate, refer them to the physician's health program first or the healthcare professionals program first, and remind them that impairment doesn't end a career, but untreated addiction will. The long-term benefits of a colleague in recovery are enormous. It's an incredible life in recovery, and I wouldn't have any of this if there weren't people in place who identified me when I had a problem, got me the help that I needed, and gave me an opportunity to show that I could deliver back and give a tremendous amount of help back to the healthcare community and the population in general. So thank you very much. I appreciate it. Here are my contact information. If there's anything that I can do to help, I know this was a whole lot, please let me know.